So welcome. I'll just take a minute to say welcome everybody to this Friday's CFAR conference. Thank you for joining. I don't think we have any major announcements today. I don't know. I don't see Joyce, so I don't know if there's any clinic announcements. Next week, please join us for Todd Foho, who's going to present on the effects of potential federal policy changes on U.S. HIV transmission using a simulation model. So that should be very interesting. And then we will have a case conference also coming up. So please feel free to send along any cases you want to discuss. And thank you, Irene, for sending me one this morning. And with that, I will turn it over to Chloe Thio, who is going to tell us about what to do about hepatitis B.
Thanks, Eileen. So I'm not going to tell you exactly what to do about hepatitis B.
What?
Maybe that's what you want to hear instead. So we've been working in the clinic to make sure or to try and minimize the risk of reactivation, hepatitis B reactivation in people who are being switched to nucleoside-sparing regimens, which, as we all know, are becoming more and more common. I think some of you, all of you, may have received a notice from an email from Joyce about some patients that you have that are on nucleoside-sparing regimens who may not have been up to date on their hepatitis B screening, or maybe she did it for everybody, regardless of what regimen they were on. But anyway, and the part of that, Joyce asked me also to just talk to everybody about the risk of hepatitis B reactivation in people with HIV who are taking nucleoside-sparing regimens. So that's kind of the background for this talk. And so let me just share my screen and get this presentation up. So can you all see that?
Looks perfect.
Okay, great. So let's just jump right into it. So let me just advance this here. So this is the outline. So when I've heard from people who have given talks that a good way to have people remember what you want them to remember is to tell them, then tell them again, then tell them again. So I have organized this, as you see an outline. I'm going to actually start with the conclusions, and you'll see my last slide is actually the same as well. And in between, I will tell you about why those recommendations exist. So hopefully you'll have heard them several times through the course of this and be able to remember at least some of them. All right, so the first slide is the DHS guidelines. This is actually, I've broken this down into several different slides, but it's all from the DHS guidelines. So if you look at the bottom, I'll just point out that there's the link. This is the OI guidelines. And I'll also point out that some of these recommendations are, as of now, unpublished. I'm part of this panel, and we're actually working on updating these guidelines, and especially this particular part of it. So some of these will, if you go back and read the guidelines, we'll read a little bit differently. In the next couple of months, hopefully we'll have these set to similar to what the language of what I'm going to show you here. All right, so the first one, which isn't changing, is before switching to a nucleoside-sparing regimen, check the triple panel, which includes the surface antigen, the core antibody, and the surface antibody, unless it's been done within 3 months prior to the time you're going to switch. And I'll just send a reminder out there to everybody that if your patient is getting their labs done in Hopkins, those 3 tests are all in one panel. You don't have to select them individually. If someone is a known prior vaccine responder, you should check the surface antibody. And if that's negative, they should be revaccinated. So in people with chronic hepatitis B, and we'll go over the serologies in a minute, the switch to a dolutegravir 3-TC or a nucleoside-sparing regimen without hepatitis B treatment, meaning tenofovir or entecavir, should be avoided. In people with HBV recovery, So people who've had hepatitis B and recovered from the infection, most commonly spontaneously, but occasionally you might have had someone with treatment-induced clearance. The switch to dolutegravir 3-TC or nucleoside-sparing regimens without additional anti-HBV therapy is appropriate, provided their HIV RNA remains undetectable. And then the next recommendation is in people, and this is the one that's changing the most, in people with isolated core antibody positivity, which is a very confusing scenario. We'll talk more about that in a second. The switch to dolutegravir 3-TC or NUC-sparing regimen without additional anti-HBV therapy can be considered in those who have undetectable hepatitis B DNA and will get ALT monitoring. And if someone does, these individuals should also be vaccinated prior to the switch. And then if anyone who's not receiving tenofovir, regardless of their prior vaccination status, even if you've checked a surface antibody before, they should get annual surface antibodies just to make sure that they have not lost their surface antibody. All right, so let's talk about the hepatitis B screening panel. So up on the top are the 3 tests in this triple screening panel. And the easiest way, I think, to think about this is to just focus on the surface antigen. So if somebody is surface antigen positive, then there should be a light that goes on in your head that says this person likely has chronic hepatitis B. They may also have acute hepatitis B, but you could probably get that from the history if they've had a recent exposure, but most likely they have chronic hepatitis B. The true definition of chronic hepatitis B is being hepatitis B surface antigen positive at 2 visits 6 months apart, and that's the best way to distinguish from acute hepatitis B. You can also see that those individuals who have chronic hepatitis B are also core antibody positive. The core antibody just signifies anyone who's ever been infected with hepatitis B. All right, so the next one is to think about the people who are vaccinated. So those people only have antibodies to surface antigen, and that's because, as I mentioned, the core antibody is only positive in people who have been exposed. If they've been vaccinated but not exposed, they'll only be positive for surface antibody. All right, and then we move to the other 2 categories of people that are core antibody positive. So people who've recovered from an infection, the HBV recovery group, they are positive both for core antibody and surface antibody. And then there's that isolated core group, and that's really what it sounds like. So they're negative for surface antigen, negative for surface antibody, and positive for core antibody. And this is a very complex group of people, and a lot of times we don't know exactly what's going on with them. They either have chronic hepatitis B, but very low levels of surface antigen, or potentially mutations in the surface antigen that aren't being detected by the surface antigen test where in the lab that is done at. So there are different surface antigen tests, and each lab uses a different one, and each of them may miss certain mutations. There's a patient that we had actually here at Hopkins who was a hemodialysis patient who had chronic hepatitis B, but repeatedly tested negative for surface antigen, and so no one was aware that this person actually had chronic hepatitis B. Ended up going to University of Maryland for an acute hospitalization, and her surface antigen test there was positive. When we looked more and did some sequencing on her, it turns out that she had a mutation that wasn't detected by the surface antigen test that is done in our lab. It's an uncommon scenario, but it is possible that that's why someone has the isolated core antibody positivity. So, the recommendation really is not in everybody, but if you're going to go to nucleoside sparing regimen, just to check a hepatitis B DNA in these individuals, just to make sure they don't have chronic hepatitis B. All right, so now
Chloe,
that,
can I ask you a question
yeah, go ahead.
about the vaccinated scenario? Is there any other reason that people would have that scenario besides being vaccinated? And the reason I'm asking is because in research, if we get that result, we always have to follow up and confirm that they've been vaccinated. But doesn't that confirm that they've been vaccinated?
There should not be any other serious scenario where they have this. I mean, it's, it's possible that they were recovered and that they lost core antibody. In some longitudinal research cohorts that I've worked in, we've seen very few people lose core antibody, but then in those situations, they also tend to lose surface antibody. So I think in my mind, it would be a very rare scenario that someone would be only surface antibody positive and have not been vaccinated.
Yeah, because then we're asked if we can't confirm whether they've been vaccinated, then we have to do a PCR and it's a whole nother step.
Yeah, I
Which I
can
don't
see
really
that for a research study, they may want to do that, but for clinically, if you see that, they've been vaccinated.
Okay, thanks.
And then the last scenario, obviously, if they've never been exposed or vaccinated, then they're negative for all of the serologies. Yeah, and so please, anyone, just if you have a question, just shout it out, because I can't actually see the chat. Or if someone wants to monitor chat and shout out questions, that's fine as well. All right, any questions on that before I move on? All right, so what does hepatitis B reactivation mean? So there are definitions of it. For research, sometimes people use different definitions, but the definition I think is most reasonable, I think, is also in the ASLD guidelines, which are the liver disease guidelines, are greater than 1 log or a 10-fold increase in hepatitis B DNA. If someone is hepatitis B DNA negative, going to hepatitis B DNA of greater than 100 IUs per ml, or someone who was surface antigen negative becoming surface antigen positive. All right, so why does reactivation occur? So I'm not going to go through the whole hepatitis B life cycle because that's very complicated, but I think it is worth understanding a little bit about what's going on in the liver to understand why reactivation happens. So in the nucleus of the hepatocyte of people, of cells that are infected, there's this part of the hepatitis B that we call the cccDNA. It stands for covalently closed circular DNA. And it's kind of, you can see the picture there, it's kind of wrapped around itself. It's very stable. It's called the mini chromosome also. And it actually has histones on it, so it's super stable. It's the template for replication of all viral RNAs. I've only depicted one here, which is the pgRNA or the pregenomic RNA, because that's the one that gets taken out into the cytoplasm and gets encapsulated. And then once it gets encapsulated, that's where reverse transcription occurs. And so this is where your treatments work, your lamivudine and your tenofovir and the entecavir, they inhibit this step, this reverse transcription. So obviously they're not doing anything to the cccDNA. So the other interesting thing about cccDNA is that it can be silenced. We're still trying to figure out all the mechanisms of it, but we do know that people on nucleoside or nucleotide analogs, there's some degree of this silencing that goes on. So, which basically means that it's not transcribing any of the RNA products, so that pgRNA isn't being made, but that cell is still infected. And these cells can live for quite a while, and it's not actually clear, some of them may be longer lived than other cells, but it's these cells that are the ones that can reactivate if the immune response decreases. For example, if their HIV RNA is no longer controlled, if their HIV is no longer controlled and HIV RNA goes up, or if their cccDNA is silenced through NUCs, nucleotide analogs, and you take those off, then they could potentially reactivate. So that's kind of the quick and dirty about why reactivation can occur. even after a spontaneous recovery from hepatitis B, so people who are core antibody positive and surface antigen negative and often surface antibody positive, there is some evidence of this low level transcription going on. So this was a study that was done by one of my former grad students, Tanner Gruda, who took 13 liver biopsies that were part of the ALIVE cohort who had recovered from their hepatitis B infection. He isolated DNA and RNA from them and did a very sensitive PCR to detect low copy number. And he found about 2/3 of them had either DNA or RNA positivity. So suggesting that even in these people who've spontaneous recovery, that there is some low level of transcription or replication going on, which isn't surprising to us, because that's why someone who's had hepatitis B recovery, if you put them on immunosuppressive therapy, they can reactivate. If their CD4 count gets too low from HIV, they can reactivate as well. All right, so we've done through the first part of this. I'll just stop there and see if there are any questions that anyone has here. All right, so the next thing I'm going to talk about is what is the evidence for reactivation with nucleoside-sparing regimens. So this is a study that was in the VAXXER cohort, the Veterans Aging Cohort study. It was presented as at CROI maybe 4 years ago and still hasn't been published. But they looked in, so this is a large database of veterans in the United States. And they looked for all individuals who were switched to a nucleoside-sparing regimen who were core antibody positive. So, and then they divide them into 4 groups, those subgroups A, B, C, and D. And then they said, okay, were they ever surface antigen positive prior to the switch? Yes or no? Were they ever surface antibody positive prior to the switch? Yes or no? You can see the number of participants. The largest number, almost 6,000, had never had been surface antigen or surface antibody positive that they could see in their records. Obviously, if someone hadn't been in the system the whole time, they wouldn't know prior to that. But at least in the records, they had never had evidence of positive surface antigen or surface antibody. About 1,000 people had never had a positive surface antigen, but did have a positive surface antibody. About 200 had had a positive surface antigen at some point prior to their time they were switched. And then 40 people had ever been both surface antigen and surface antibody positive. You can see the number of cases of hepatitis B reactivation in each of those groups. So not a large number, but I think what's very interesting about this is that those people who had never had a positive surface antigen in their records, and the VA study is a good place to do this because they do follow people for a long period of time, that risk of reactivation is quite low. But if they had seen that they had had a surface antigen at some point, so maybe people had lost surface antigen with treatment, you can see that their risk of reactivation was much higher, 20% and 17%. And if you compare groups A and B and compare groups C and D, whether or not they had surface antibody doesn't really change their risk of reactivation. Oops, I went backwards. All right, so that's one study. So another interesting study is from the OPERA database, which basically is a large electronic database. Their study design was they had 5,343 people who had 6,252 tenofovir interruptions. And they define an interruption as greater than or equal to 45 days with at least one ALT, hepatitis B DNA, or hepatitis B surface antigen during the interruption. So if they didn't have those, any of those data, they didn't count them as an interruption because they couldn't actually evaluate it. These interruptions were classified as either with a hepatitis B med or without a hepatitis B med. And then they analyzed the risk of reactivation in 3 different groups, either high risk. So those were individuals who were still surface antigen positive, and that was 69% of the study population. Moderate, so those people who were core antibody positive, either with a negative or missing surface antigen and surface antibody. That was about 20% of the cohort. And then the lowest risk were those people who were positive for surface antibody, and that was 11% of the cohort. And they defined reactivation a little differently than what I had mentioned at the beginning. For them, if someone was in the high risk group, they had to have a greater than 2 log increase in hepatitis B DNA, or greater than 1,000 if they were previously undetectable. And then for the low and moderate risk group, any detectable hepatitis B DNA or new hepatitis B surface antigen positivity was counted as reactivation. All right, so here are the results. So the median time on tenofovir was 24 months. The median time before the interruption, the median interruption time was 23 months, and you can see the range there. In terms of HIV RNA levels in this group, 54% were less than 50, 11% were 50 to 200, and about a third were greater than 200. The CD4 count was greater than 500 in about half of them. I think one of the things that's very notable is that in this group, over the 12 months, no hepatitis B DNA over 12 months was collected in 92% of these people with interruptions. And there was no hepatitis B surface antigen in 72% after the interruption. So this is the data that are here are only for those people who got DNA or surface antigen tested. Hard to know if it would be higher or lower if more people had been tested, because as we'll see in a second, there are people who reactivate who may not be immediately clinically evident. So if you look on the graph and to the right, there's the high, moderate, and low groups that we talked about. If we focus on the high, so these are the folks who were surface antigen positive. You can see this is the incident rate on the y-axis per 100 person years. So the reactivation rate in those who are high was pretty high. So that's 10 per 100 person years. Only about half of them were actually clinically evident with an ALT flare, and about 3 per 100 person years had both. And if you look in the moderate and low risk groups, the incidence rates were a lot lower. And although they did have some a little more ALT flare. So overall, the reactivations were 2%, 70%, 2%, and less than 1% in the high, moderate, and low risk groups. So this, these type of data feed into the recommendation and the isolated core antibody positivity that you can consider switching them to the nucleoside sparing regimens, because these reactivation risks are not that high. And I think the VAC study that I showed you on the slide before this also supports that. But monitoring is important. So this is another study from Italy, the Icona cohort. These individuals were surface antigen negative at 2 time points prior to stopping tenofovir. And then they looked at individuals at either time point 1, which was 12 months after stopping, or time point 2, which is 12 to 24 months after stopping. Not everybody got testing, made it to time point 2 for various reasons. So overall, they had 101 people on tenofovir for a median of 4.3 years. About 2/3 of them were surface antibody positive, but with very low, pretty low levels of surface antibody, with a median of 69. 72% were switched to a 3TC based ART, a limiting based ART regimen, even though they weren't on tenofovir. So at time 0, they used a very sensitive PCR called ddPCR, and they did find that about 1/3 of them had low level detectable hepatitis B DNA, although they were, not DNA positive by a regular assay. At time point 1, about 13% had DNA greater than 10 IUs per ml, so low, but detectable, and only 2 people were greater than 100. And at time point 2, remember they had fewer people that made it to time point 2, 17 individuals or 43% had hepatitis B DNA greater than 10, and 11% had a hepatitis B DNA greater than 100. Out of these 17 people that had DNA greater than 10, 12 of them had low level detectable virus at that time point 0 by that very sensitive PCR assay. So overall, I think this also shows that the reactivations are not that high, and if they happen at a pretty low level, and you could catch them with monitoring. So I just wanted to also point, there are many other case studies of case reports of people who have had reactivation. These are just a few of them. There's one person who was switched to long-acting cabrylpivirine who had an acute hepatitis B 9 months after the switch. They had been vaccinated, but the response to the vaccine was unknown. There's a study from sub-Saharan Africa that showed out of 60 individuals, 6 or about 10% likely had hepatitis B reactivation when they were switched to darunavir, boosted darunavir monotherapy. There's a study presented at CROI last year on this wasn't the main part of the study. The main part of the study was looking at this switch to doravirine islatravir from Biktarvy. And data were presented at week 48 in terms of HIV outcomes, but they did also say that they had 2 cases of acute hepatitis B and 2 individuals who were core antibody and surface antibody negative prior to switching, which is why it's important to check people for whether or not they've been vaccinated, prior to putting them on a NUC-sparing regimen, because there are cases of acute hepatitis B, as is the first case report as well. And then their reactivation rate in people who have been core antibody positive was 2.3%. With low hepatitis B DNA levels, without any surface antigen or elevated ALT. So, 2% seems to be a pretty common number in these various studies. And also presented at CROI last year, 104 individuals who were randomized from Biktarvy to islatravir. One person they reported discontinued that due to hepatitis B flare. So it does happen, although not that convenient, not that common. So I just did want to point out that, in these studies that I've shown to you, the reactivations haven't been that serious, but they can be. And that's why it really is something that we want to avoid. There are several case reports of, serious reactivations. This was just one of them that I've pointed out here. This is a 66-year-old male with co-infection. He was known to be surface antigen positive. Then he was switched to a new physician who didn't realize that that person was surface antigen positive because the test had been done years ago. That physician put the patient on dolutegravir-rilpivirine, and that individual ended up reactivating with super high hepatitis B DNA levels, went on to liver failure, and required a transplant. So, important to remember that this can be serious. All right, so once again, ending where I started. So before switching to nucleoside-sparing regimen, check the triple screen. Make sure that you know whether or not your patient may be surface antigen positive, and you just didn't know it because you just inherited the patient. So it's important to check that triple screen if not done within the prior 3 months. If they're negative for surface for all of them and you want to put them on a NUC-sparing regimen, it's important to vaccinate them, because especially with the hepatitis B now, response rates are pretty much 100%. People do get acute hepatitis B when they're on these regimens and they don't have surface antibody. If they're a prior vaccine responder, make sure you check surface antibody, and if not, you can give them the vaccine series again. In people with chronic hepatitis B, switching to these NUC-sparing regimens or dolutegravir 3TC should not be done because they will reactivate. In people who've recovered from a hepatitis B infection, so positive for both core and surface antibody, switching to dolutegravir 3TC or NUC-sparing regimen is reasonable without any other hepatitis B therapy, provided that their HIV RNA is remaining undetectable. If they're switching to an injectable, chances are they will remain undetectable and they will not reactivate. And people with isolated core antibody positivity, they are a mixed bag of people. You could certainly consider switching them, but I would check to make sure their hepatitis B DNA is undetectable, and then they should be monitored with ALT and hepatitis B DNA during their treatment. What's recommended is monitoring every 6 weeks for the first 3 months, and then every 3 months, 3 to 6 months thereafter. And if they should all be vaccinated prior to the switch as well. And then if they just as a reminder that people on these regimens should have annual surface antibodies, and if their surface antibody titers drop, they can get a booster dose of the HEPLISAV-B. So I will stop there and I'm happy to answer any questions. I hope that was clear.
So that was amazing, Chloe. So I'll start off with one question. So if you have someone who is previously positive and is now negative and you're revaccinating, when do you check to see, and do you ever do multiple doses?
So someone who was surface antibody who had responded to the vaccine and was surface antibody positive documented. Is that what you're asking?
Correct.
Yeah. So I would vaccinate them once and then check a month afterwards.
Okay.
And if they're negative at that month, you can give them a second dose.
Okay.
But my guess is if they responded before, you could boost them pretty easily.
Right. They should boost, right?
Yeah.
But and then so in the scenario of chronic surface antigen positive Hep B, how frequently do you check that, and what is the likelihood of someone ever becoming surface antibody positive? So they're surface antigen positive, core antibody positive, surface antibody negative. What's your practice for how frequently you screen for surface antibody conversion? And then just to explicitly say this, because it came up in the clinic with a resident, is there's no role for vaccination because it's the same antigen that's present from the virus as would be in the vaccine.
Right.
Although sometimes we feel like, oh, but we'll get the vaccine, but they're like bathed in this already, right? So, but how frequently do you check to look for a conversion?
Yeah, so just before I answer the question, I'll just say that there's a ton of surface antigen there.
Yeah.
And so it's just so much surface antigen that the little bit of surface antigen they get with an extra vaccine isn't going to do anything. But so in terms of monitoring them, I monitor them every 6 months, just like I do so not with surface antibody, with surface antigen and hepatitis B DNA. They should also get screened for liver cancer every 6 months with an ultrasound and alpha-fetoprotein. In terms of checking for surface antibody, I don't check for it unless they become surface antigen negative.
Okay.
They won't be surface antibody positive. They won't be surface, I'll just leave it at that. They won't be surface antibody positive. They remain surface antigen positive. But that being said, also part of the guidelines is that they should be monitored at least annually for surface antigen. I do it every 6 months because in people with HIV, there does seem to be a higher rate of surface antigen loss with treatment than in people without HIV. So it is worth monitoring to see if your patient is losing surface antigen.
And I'll just mention, I think Dave Thomas has mentioned this before, that if you give the vaccine, don't check for surface antigen in the blood that day.
Yes,
because
correct.
it will be positive.
Yes.
Right.
Yes, exactly. It will be positive. We occasionally get consults like that. But yeah, so don't check it right away.
And then there's a question from Sarah Rivas in the chat because she missed a little bit at the beginning, but any use in measuring quantitative surface antibody titer and using a higher cutoff or wanting another booster dose if you're core and surface positive and going on to a NUC-sparing regimen?
Yeah, so Dave put his comments up, they can be positive for up to 2 weeks. Yeah, so in people who are isolated core positive, did you say something, Eileen?
So for Sarah's question is if someone's core positive and surface positive, is there any
Okay.
role for a titer
Oh, if
of
someone's
the
no,
surface? Right.
there's no role for a titer. No.
Joyce.
Hi, thank you so much, Chloe. For these people who are core antibody positive and they're isolated and Hep B DNA is detectable but not quantified. Like it's not at
And
the
they're on
level
tenofovir.
of quantification. No. So this is a patient, and I know that you were consulted about him before, who he has some renal issues, and he's now on dolutegravir rilpivirine, and he's isolated core antibody positive. His Hep B virus DNA is detectable, but less than the limit of, quantification. And he refuses vaccination. And I guess I'm just sort of wondering about these people who have, very low level but detectable Hep B DNA. They have intact, good immune systems. Like, what's the risk of flare if they remain immunocompetent? And their HIV virus is well controlled.
Yeah, so these people are probably on the spectrum of having some low level of surface antigen. So these are people who, I think it's important to remember that when we get these tests, they are, negative or positive, but it's based on some cutoff of, the optical density, because there are ELISAs of the reader. So if they're just above or below that cutoff, they'll be reported as either positive, they're just above, or negative, if they're just below. But we only get their labs every 6 months or however often we get them, and they could easily be oscillating up or down right around that cutoff, and we just happen to be when we happen to catch them, they're one or the other. So my guess is that this person is probably low level surface antigen positive, given the fact that he does have some DNA. I think in this particular person, since he, couldn't get tenofovir, I think, and maybe didn't want to take entecavir, that and hadn't been on tenofovir, I didn't see any reason that he couldn't go to dolutegravir, rilpivirine, as long as he was being monitored. And if someone like that had been on tenofovir, I would not recommend switching them to a NUC-sparing regimen.
And so, like, checking Hep B DNA is like now recommended for these isolated core positive people.
So they're different opinions.
Okay.
Some people feel like they should all be checked. My feeling is if they're on tenofovir, they're going to be negative. It's not going to tell you anything. But if you want to switch them to a NUC-sparing regimen, I mean, if they're on tenofovir, you can check it right then, and but if they're not on tenofovir, I would check it before starting a NUC-sparing regimen. If a new patient comes in, for example, and you get the screening panel and they're only positive for isolated core, and you put them on a NUC-sparing regimen, I would just check their hepatitis B DNA in that situation. Does that make sense?
Yes, I have one, I'm sorry, quick follow-up question. So for people who do not have HIV and they do have hepatitis B, chronic active, it used to be that, like, unless they, had like a very high Hep B DNA and or like high elevated LFTs, you wouldn't necessarily treat. Has that changed for people who are HIV negative?
Yeah, that's a good question. There's a big debate in the field about this. As infectious diseases physicians, we always feel like, yes, they should all be treated. They have an infection, but from the hepatology standpoint, they don't always feel that way. And part of the reason is because we can't cure hepatitis B yet. And these are lifelong drugs, and once you start them, they're on for life. So the WHO, so there's lots of different societies that have lots of different guidelines. The WHO has actually switched to guidelines that are more in line with almost treating everybody. They have, criteria. As long as you meet one of their criteria, then you can be treated. The ASLD just came out with some new guidelines, which allow for treatment of more people. They are pretty much sticking with their older recommendations, with the only difference is that if you don't meet the strict criteria for treatment, then they say that it can be considered with discussion, with the physician. So yes, they can be treated now, but not truly recommended.
Yeah. And I mean, the reason I ask is, some of this room for shared decision making, right?
Yeah.
With these people who are isolated core antibody positive, they're Hep B DNA positive, but it's like very low level, they're immunocompetent. So thank you.
A few more quick questions from the chat. There's one from Chris Hoffman. So someone with a good response to vaccination, how frequently do you repeat an anti-Hep B surface antibody titer, assuming the person is not on tenofovir?
The recommendations are to repeat them annually, and if they fall below, to give them a booster dose.
And then from Natasha, if you have someone on a NUC-sparing regimen who is, so every year, hepatitis B
Yes.
surface antibody.
Yes.
If you have someone on a NUC-sparing regimen, historically antibody positive, but it's been 12 months and they're known core positive, do you also check a surface antigen when you check the surface antibody?
No,
Just check the surface antibody first, because if right, got it.
because if they have surface antibody, then there's
Yeah, and then that case that you mentioned of the surface antigen negative chronic Hep B, is that something we should actually be thinking about, or is that like just so unusual that it's like not worth
it's
really
so
considering?
unusual, but the only reason I mentioned it is because it can happen, and it's the type of thing where if you are switching your patient to a NUC-sparing regimen and you didn't know if they're on tenofovir, obviously there's no reason to check the hepatitis B DNA in that situation,
Right.
because they're on tenofovir. But if they aren't on tenofovir, then I mention it because it can occur, and just to make people aware that just because the surface antigen is negative doesn't mean that the hepatitis B DNA is negative. And that's the reason for checking hepatitis B DNA in that situation.
Perfect. And then
Although, there are people that, like I said, in someone who's isolated core, they think they should all be checked for hepatitis B DNA. But I think that the studies don't show that there are that many people that are DNA positive, even, even people not on tenofovir, that I don't feel like it's worth checking everybody.
Yeah, Chloe, is another way to think about it, that which I know is the way you think about it, so that's why I'm saying it, is that it's not surprising that the DNA is there. It's just about, if you look hard enough, we think most people with the anticore do have hepatitis B in their livers. So the question is there enough hepatitis B in the blood to be clinically important? That's the question. And there's, as Chloe said, one person, well, maybe more than one, but at least one who feels like 10, that tests everyone because occasionally it's positive. And an alternative way to think about it is everyone could be positive and will be positive if you look hard enough with sensitive enough tests. And aside from a very isolated set of findings in South Africa, no one's ever found high-level viremia, meaning more than 500 international units per ml, in that context that we're describing. So the time to look is when it might inform your care. You should assume it's there. And then if you're switching to a TAF or tenofovir naive regimen, then the reason for checking it then is so you have a baseline, an anchor to find out if reactivation occurs and to what for your second time point. And otherwise, there's really no clinical value to doing it. Chloe, are you comfortable with that way of thinking
Yeah.
about it? I know you think about it that way, but it's not that it's shocking when it's there. Look at that study she presented from the Alive cohort. If you look in people's livers, it's there. That's why they get reactivation. Sometimes when you give Hep C drugs, that's why they get reactivation if you give them rituximab. It's there. We should think about it that way.
And
But
that's because that CCC DNA is there, like I mentioned, it's there. We know that it's there.
yeah, the question is, when is it actionable? And depending on, and Chloe made this point really clearly, that depending on the sensitivity of the tests and how often they're done, you will find positive results over time in these individuals because they have very low level Hep B in their liver.
And this is likely a dumb question. I just don't know the answer. If you tested ALTs and DNAs, would they co-vary, or does the ALT stay low in a lot of people that have reactivation of the Hep B? Because ALT is obviously a lot simpler and it's done anyway. And I wonder if it could provide the sense of rebound that the DNA could at much greater convenience.
It doesn't reliably show you when rebound is occurring at a low level. Obviously, if their DNA is really high, then it will show it to you. But if their DNA is 50, 100, the ALTs may not go up that much. I guess if you're really paying very close attention, it might go up a little bit, but in the studies that I've seen, they, look at, does it go above the limit of normal? And that doesn't seem to occur.
And do you care if
necessarily.
it goes to 50 or 100, the DNA?
I think it depends on the person. It's one of those things that's the shared decision making, right? You tell the patient you were undetectable and now you're 50. I would certainly check them a lot sooner. I wouldn't wait 6 months. I might check them in another month if they decide they want to, continue on their tenofovir-free regimen. But I think that's the time to talk to the patient about what's going on. Some people could stay at 50 for forever and, and they'd be fine.
I'm just wondering if
We don't know
ALT
who those
tracking
patients
would,
are.
if ALT tracking would give you 90% of the same information, even
Not
if you
from the
followed
data
it.
I've seen.
Okay.
Sonia, did you have a question?
Yes. This is kind of changing gear from the antibody antigen monitoring. So Kathleen, if you were along those lines, I could wait, but I had a question about data on Cabenuva and adherence to oral Hep B agent in people who were HIV and Hep B co-infected. So I was wondering if anyone in clinic have had patients who have hepatitis B, HIV co-infection and request Cabenuva, mainly because I have one patient who falls in that line. And I've been hesitant to offer oh, you can go on Cabenuva plus entecavir because he's a young guy. And then I'm worried that he's just not going to take entecavir or take tenofovir. But then I also am wondering if I am gatekeeping or being too concerned. And so I was curious about, I haven't said no, but I've led him more to just staying on Biktarvy because what is really gained from LAIs plus tenofovir than our LAIs plus entecavir.
And I'll just jump in to say, Tracy AG put a question in the chat that kind of dovetails with that, with this question around what are the consequences of going off therapy and having reactivation like that might happen to Sonia's patient, even with continued HIV viral suppression in terms of shared decision making. So not the same question, but I think gets at this same kind of idea.
Yeah, so I've never had a patient like that. I don't know if anyone else has. If you have, please speak up. So Sonia, I share your concern about the person not being compliant with their entecavir. Is there a reason that that person said they wanted to switch to long-acting cabalpivirine?
He just he doesn't like taking the pill every day, and he's like a young guy, and he like travels
Yeah.
and does various things, so it's kind of a feat. But he does like really want his HIV to be suppressed, so he does work to take Biktarvy every day with some missed doses.
And
So
have
he
you-
would be someone who would be fantastic for Cabenuva
Yeah.
if he didn't have Hep B.
Have you told him he'd still have to take a pill for his Hep B?
Yes, and then he's been like less interested,
I
but
see.
like I was pretty firm, like I don't think it's a great idea because you'd still have to take a pill for your Hep B, but I could also like have framed the shared decision-making conversation differently too, but I kind of led it in one direction.
Yeah,
It
I
looks
mean,
like it looks like Barb Wilgus and now Dave Thomas have a patient who's on Cabenuva and entecavir.
Okay.
Yeah, I'll
and how does
say
that work for you guys?
this is my patient that she remained at the Moore Clinic when I left in 2020. So I haven't, but she calls me like almost weekly, so I know everything about her. But now she's Dave's patient. But she had the reason why she switched to long-acting injectables wasn't anything to do with adherence. It was she was having lots of renal trouble and finally just had to be not on any like TAF or tenofovir or anything. And she has also had so she takes a ton of other oral medicines for like diabetes and probably hypertension and stuff. So so it's a little bit different, but she also I'm trying to like dust off my memory. Like I had presented her at case conference a long time ago anyway, because she had always chronic inactive hepatitis B, where she never lost her surface antigen, never developed surface antibody, but also never had a detectable Hep B DNA. So when it was time to kind of like remove her from tenofovir because of her renal stuff a long time ago, I had presented her then, and actually, so she's been on entecavir for a long time because of the renal issues. So it's not quite the same, but she's 100% happy on Cabenuva and takes all the rest of her medicines.
And along those lines, how forgiving is hepatitis B of missed doses?
Less forgiving than HIV. I mean, as
Okay,
we all know, we have those patients who say, oh yeah, I take it 4 times a week or whatever, and you check their HIV RNA and it's undetectable. With hepatitis B, there are a couple studies that have been done that you really need to have 100% compliance. And that's because it's just not that potent. The nucleoside allergy is just not that potent as single agents. I mean, if you think about if you just treated HIV with lamivudine, for example, it wouldn't be, let's say resistance wasn't even an issue. It just wouldn't be that forgiving for missed doses. But it's because we treat with so many potent medications.
Thank
And I believe you said that there was another, I can't remember what else you said there was another one that was related to Sonia's question. I can't remember what it was anymore.
Yeah, no, just this idea of like how like when we talk to patients about taking therapy forever for their HIV, we say things along the lines of like, and if you stop everything, stop it all at once. But there's no like rebound scariness other than that your HIV comes back. And so
Yeah.
I think the question is really like, how scary should we be about rebound in terms
Yeah,
of
so
when
I mean, I
someone
presented
commits?
that's why I presented that one scary case of the guy, at the end who reactivated and had to have a liver transplant. So it can be scary. There are case reports, there's lots of case reports out there. I've never seen, there's not such thing as a case series with numbers. So I think it's uncommon, but it happens. And you can't predict who it's going to happen to.
I have seen it once. I had a patient who was brought by Partners in Health from Haiti because she had a baby with a disability right after the earthquake in Haiti, they fit her in my clinic because they asked us to see her just as a favor. She had a UTI, but she did not have a UTI. She had hyperbilirubinemia and a marked change in her urine that was associated with profound hepatitis because her ART had been discontinued when she came. So she was a Hep B reactivation. But Kathleen. You've been so patient.
Question has nothing to
Oh,
do with
yeah.
what we've been discussing. It's more about liver cancer screening. And maybe I don't really understand the pathophysiology, but I thought it was integration. And I don't usually screen my patients who are just core antibody positive. But now hearing Dave say that they're probably all infected, they are. I'm wondering whether I should do it. And then I have a couple of people who have had functional cure who don't have any, like they're young, they're I don't think if I read the latest guidelines, they don't have cirrhosis, they would necessarily, I'm a little bit unsure about what to do with these people.
So the guidelines say that if they're surface antigen positive, they should be screened.
No, I mean antibody positive core, like they had
Yeah, no, they don't need
and
to
now
be
they-
screened. No, they don't need to be screened.
Okay, so even if they have this like a little bit of virus there integrated, that doesn't matter.
Correct. Their risk is not that high.
Okay.
You know, if we get to drugs that are better at curing people than what we have now, I mean, the rates of cure with treatment are quite low. And so if you have a 60-year-old who's had hepatitis B for 50 years or 40 years, and then we have these, potentially new drugs that then cure somebody, would you still screen them for HCC? I might in that situation because that's very different than someone who gets an acute infection at age 20 and recovers pretty quickly. They may still have some integrated DNA, but it's going to be a lot less than the person who had 40 years of
I see.
hepatitis B.
Okay, that makes sense. And what about the people who did have chronic Hep B for some time and then are functionally cured now? I guess it depends on how long that you thought they had this chronic Hep B.
Yeah, I mean, so that hasn't really been studied because there aren't that many people who've had functional cure. I think for me, it would depend on their age, their ethnic background, what country are they from, do they have a family history of liver cancer? All that
Yeah.
would play into it. How advanced is their liver disease? If they have more advanced liver disease, they're more likely to get liver cancer. I might be more likely to screen. So I think that's very individualized.
I'll just say that I don't have that many patients with Hep B, but I have two that have. So my N of people who, and these are people with HIV, is not that rare. It's two
You mean
out of,
functional
like,
cure?
10.
Yeah, I mean, so as I mentioned, functional cure does seem to be more common in people with HIV. We don't really have time to go into, why that might be. But that's why the recommendations do suggest annual screening for surface antigen in people who are co-infected, because you might find people who lose surface antigen and have functional cure.
Yeah. Okay, thank you.
There was a presentation at ASLD last week that looked at the HCC risk in a very large cohort according to surface antigen loss. And when it was lost, it dropped below the 1% threshold for where HCC surveillance overall, but just exactly what Chloe said, obviously individualizing it based on age and sex makes a lot of sense.
Well, I think office hours with Chloe should be like a regular conference here for the CFAR because
Happy to do it.
everybody's got their Hep B questions that we are can all like just walk down the hall. So thank you so much for doing this, Chloe. And
No problem.
yeah, thanks everybody. Hep B therapy. Yeah, it's like she's our Hep B therapist. So thank you so much, and
No problem.
have a great weekend, everyone.
Bye-bye.
Thanks, Chloe. Thanks, Eileen.